So hello everyone, welcome back to my channel. Today I have brought a very different rare case, that is vaginal leiomyoma. I will be discussing about the case. Before that I just wanted to tell you that this is a very rare case. Okay, so around 300 cases only it has been reported in India. And how we examine the patient here, the problem was that we could not examine the patient clinically because the patient was unmarried, and the vaginal leiomyoma was present, a mass was present, but we could not examine her. And so what happened, we only have to rely on the imaging techniques, and then we examined the patient's per abdomen, and also we thoroughly saw the ultrasound image, the live ultrasound, and then we did the OT, and then the histopathology, it confirmed vaginal leiomyoma. So let's discuss that vaginal leiomyoma, it is a very rare benign tumor that is arising from the smooth muscle cells in the vaginal wall. So most commonly it is less common than the uterine fibroids. So you know that uterine fibroid, the fibroid mostly it arises from the smooth muscles, spindle shaped cells. So here it is, the occurrence is very rare, the vaginal leiomyoma occurrence is very rare than the uterine fibroids. And what is the etiology and pathogenesis? It originates from the smooth muscle fibers of the vaginal wall, and also the blood vessels is present. Okay, so it is highly vascular, pseudocapsule is also present, and it is estrogen sensitive. That means in the reproductive age group we can able to see, and it enlarged during the reproductive years. Then what is the common site? The most common site in this case also, it was present in the anterior vaginal wall, and the most common site for the vaginal leiomyoma is also the anterior vaginal wall, and it can also occur in the posterior lateral walls. So how it will present? We can see a bulging mass, or we may not be able to see a bulging mass, because if the like mass will be protruding inwards or towards the uterus. Okay, so where it is present? It is present in the anterior vaginal wall, not just below the cervix. It is present in the cervix, but between the bladder wall and the wall of the vagina. Okay, it is not present in the vaginal canal. So how that one we will know? We will know in the ultrasound that the vaginal canal is empty, it is compressed by the anterior vaginal mass. Okay, so what are the clinical features? So if the tumor is small, okay, if the leiomyoma is small, then it is asymptomatic and also a incidental finding. But the large tumors, vaginal mass or bulge will be present. Dyspareunia may be present in married women. But here this case the patient was unmarried. Okay, so there was no history of dyspareunia, only there was urinary symptoms and the vaginal mass or bulge she could feel. Okay, so but in married women, so dyspareunia can occur, difficulty in intercourse, and urinary symptoms like frequency retention and also obstructed labor, but rare. Okay, till then we could have diagnosed it. Okay, then examination findings. So it is a firm, well circumscribed mass and non-tender and also mobile. If it is large, if it is fixed, and if it does not arise and it is not mobile, then we can think it as rhabdomyosarcoma. Okay, we may think it as a malignant mass if it is mobile, fixed. If it is not mobile and it is fixed and irregular structure, okay, and invading the vaginal wall, so we may think of the rhabdomyosarcoma. And here the overlying mucosa, it is intact. Okay, then what about the differential diagnosis? It could be vaginal cyst, Gartner cyst. Okay, but it is present in the anterior vaginal wall. It may be urethral diverticulum. Okay, then it may be cystocele also. But cystocele, that is the protrusion of the bladder, that is through the defect of the vaginal wall. So this is, we can differentiate it differentiate the cystocele from the vaginal leiomyoma, and then it could be vaginal malignancy or it may be Bartholin cyst. But Bartholin cyst, it is present in the posterior vaginal wall, not in the anterior wall. Okay. Then what the investigation we did, I will show you the ultrasound image. Okay, I will show you how to diagnose that it is not cystocele, it is not any cervical fibroid, and it is not present in the vaginal canal. I will show you the ultrasound image, and then MRI is best. But as in the ultrasound we were able to diagnose the case, so we did not do the MRI. Clinically we could assess, okay, and we did not do the MRI, and also the size, extent and relation of the urethra and bladder we can just know through the MRI, and biopsies. The excision of the mass was done and the biopsy was done, and this is the final diagnosis. So what the management we did, I will show you the ultrasound image. See, this is the ultrasound image showing this one is the uterus. Okay, this one is the uterus and this one is the mass. This is the mass that is present, this is the cervix, and this is the mass that is present. See again. So this is the mass, you can see the bladder is separate, and this is the cervix. This one is the cervix and this is the uterus that is present, and the bladder is separate. And the most important is why this is not cervical fibroid, because the vaginal canal here, it is compressed and it is visible. So that means it is the mass, it is compressing the vaginal wall and it is present in the anterior vaginal wall. So this is how we clear the diagnosis. This one is the cervix, the one I am pointing out here in the image. Okay, and this one is the space occupying lesion, and say the phallus. The phallus is visible, that means the bladder is here, the bladder is intact and it is separate, and the mass is compressing the vaginal wall. See, the hyperechoic vaginal wall is visible. That means it is not present inside the vagina. It is present in the anterior wall of the vagina, compressing the anterior wall. Okay. Then what is the management? See, this one is the mass that is present, and what we did, we excised the capsule, and then see how to let me pause and just tell you that how to know the leiomyoma, that vaginal leiomyoma. It is a well defined solid mass and also it is hypoechoic. See, hypoechoic, and also posterior acoustic shading may be present, unhomogeneous in structure and located separate from the uterus, and also from the cervix, and Doppler minimal to moderate vascularity is present. I am showing here. So that is the probable diagnosis of leiomyoma. Then here we infiltrated the antevaginal and then excision is done, and then so this part is excised, and then the mass is enucleated out or excised out from its capsule. The fluid it is coming, this is not any cystic fluid, this is the fluid that we infiltrated. Okay, so this is the normal saline that is infiltrated, that was infiltrated prior to the surgery. So that fluid is coming out. It is not any degeneration or any cyst that is present. Okay, so here we can see the capsule along with the mass, and here the myoma screw is inserted. So this is the myoma screw. Okay, it is inserted and then it is excised out. See, some vascularity is also present, and here anteriorly we are just separating the capsule and the myoma. was sent for the histopathological study, and it came out to be vaginal leiomyoma. Okay. So here, see, so we have excised it completely, and then transversely the anterovaginal valve defect was sutured. Okay. See that when it came out, few blood vessels was there. Okay. Bleeding was there. Deep spaces was sutured with catgut. So what is the management family? So definitive treatment, it is surgical excision and vaginal approach is preferred. Okay, and enucleation of the tumor was done and careful dissection because it is just below the bladder, and so there was more chances of bladder and urethral injury. So prior catheterization was also done, and it is important to do the careful dissection and the excision of the mass. So thank you.